Now the last thing, this is the last assessment, and then I have one last slide, is, so what I wanted to do with documentation, I wanted to just say, number one was challenging because they're dispersed. So as Debbie said, where are they located and how do we try to get a denominator? Secondly, it's very difficult with disease incidence rates and usages of services. And I didn't talk about this, but you can have numerous clinics, private, government, NGO, in the same area, and people will use the same one depending for various, or will use different ones for various reasons. So there's a lot of double counting going on. It makes it more complicated. Then looking into existing national systems, trying to integrate. Then the last thing is this population-based surveys. And I know Jan did some in Jordan and Syria, or just Jordan? Jordan. Hopkins did in Jordan and Syria. Population-based surveys are very, very difficult in all conflict settings. In urban settings, I think they're very difficult because of trying to find out where the populations are. There are other methods, and Francesco Capecchi and others have discussed certain methods that we can use, including community-based surveillance. But we've discussed this before, and we have run into a lot of controversies over a lot of these population-based surveys in Iraq and in DRC recently. Jan discussed this yesterday in detail. So this is something that we still need to work on as a community. So some of the conclusions is that it is possible, but it's more complex in urban settings to document in these situations. The data connection is something that we really put a lot of time into, but we're still not there. So in an urban setting, you've got to deal with your level of care. You have your emergency care, you have your primary care, you have your secondary, and your tertiary care, and you need to link them all, which is quite sophisticated in many situations. You also need to link, as I mentioned, the patients versus interventions. So what we found in Jordan and Syria is that unlike in Nairobi, let's say, we're really dealing at an aggregate level, and we're looking at the data aggregated at a public health level. In Jordan and Syria, the people running the clinics wanted the information to deal with patient by patient and to try to improve their services, how many supplies. So the actual HIS that was developed by SARC, the Syrian Arab Red Crescent, was individual based throughout the clinic, and then we needed to try to use that data at an aggregate level to make policy decisions. And it was not always easy, and especially the interventions that were the patients versus the interventions and the diagnoses. So are you going to use ICD-10 codes? Because we were getting so many different diagnoses, it was impossible to try to put them all together. Very, very complicated. And the problem is it's going to vary depending on the diagnoses that you do agree upon will vary depending on your laboratory. So in a more middle-income urban center is going to be completely different than in a remote area in southern Sudan. Very, very complicated. It was very clear that, as I mentioned, the public health data, so in many of the countries that I was in recently, the clinicians and the healthcare people were much more at ease dealing with individual data, but trying to aggregate the data and then interpret it from a public health point of view, they were not very comfortable with. And so much of the data we get from Syria and Jordan still, it's very difficult to use it at an aggregate level to make it try to coalesce into one and then make decisions. Very complicated. And then, I didn't mention, that besides the patient versus the interventions, it's the costing. And that's huge. And in the past, we had enough money, we could deal with it in most situations, but especially in middle-income countries. And then what we did after Iraq, we started going to India, to Malaysia, to Russia, to Egypt, and we looked at our urban refugee populations. In Egypt, we found out, in these situations, in urban populations, we didn't have many healthcare people in UNHCR because you're only dealing with the most extreme cases, yet there's the whole other population hidden. So we found out in Egypt, I found out to my horror that we have 42 people on renal dialysis, and it's $500,000 a year continuously of UNHCR budget, and we were never consulted, etc. So costing is massive here, and what consistently happens in urban areas where we don't have medical people is, sometimes when we do have medical people, after a quarter of the year, the budget for the urban health is spent on a few amount of people, and they're not sufficiently concentrating on primary health care. And it's a big, big, big problem. Voila. That is my, just to say that in the end, what we're working on now, on our own and with some others, is to document with flowcharts, basically, how patients work in each country in urban settings, because it's completely different. Syria is the best country in a way because it's socialized and they have access. Lebanon is the worst example where they're going all over the place. So we're trying to flowchart it out. We're trying to make various tools now, information tools, on how to gather this data and link them into costing. And it's going to be a challenge, but that's for 2009. That's one of our big goals.